Hey YouTube, it's Royale with Respiratory. I hope you guys are doing well. I just thought about a video because it's so hard to make video content about respiratory therapy because there's the whole list of things on the internet. But I genuinely would like to talk about my night the other day. I think it was yesterday or the day before. I don't want to lie to you guys. Hang on. We're in April. So it was April 14th at my main hospital that I work at. And man, I had the ICU, but I was helping my partner at the time for that, or my not partner, coworker, because she had the ER, and it was crazy. But for some reason, around this time of the year, there's a lot of pediatric uh, emergencies. So I'm chilling in my little cubby that I like to chill in. It's like the doctor's office area essentially. And I just like to watch YouTube or whatever whenever I'm in there charting. And my phone's ringing. I pick it up, and my coworker's like, Royale, I need you to get the pediatric ventilator. And I'm like, uh-oh, something different. We never really used that thing. So let's see what's going on. So I'm bringing that pediatric ventilator down to the ER. I'm going in there, and there's a 1-year-old child. And for the people, whenever I make these videos, I hope you don't get like really sensitive, or because this stuff really happens. This is stuff you'll see whenever you become an RT. You never know when, but there's a possibility that it'll happen. But going back to the story, 1-year-old child, I guess they were playing in the pool or somewhere where there was water. The child fell and hit their head. Now, obviously, brain bleed. The kid's apneic, blue, molting. I think that's the term, molting, whenever you see like patches of splotch because they're not oxygenating well. And we're trying to bag this patient. We got family members in the room, and that's always stressful, but no one ever, for some reason in my case, no one ever takes the time to escort them out when we're jamming out. They just watch what we're doing. But the child was essentially shipped out. But I mean, it was genuinely a process to try to figure out how to, what to do. Essentially, we have the Braslow tape, and that tells you, there's the length of the baby. You match the tape with the baby. You find the color that they match based on like their height, and whatever the color you match, there's like this we're gonna call it a drawer case thing, bunch of drawers, and each drawer has a different color. So whatever the color the child is based on the tape, you pick the color, and it has like the ET tube, what blade you need to use, what kind of medicine to give, things like that. So this child was purple, so they needed a size 4 ET tube. The blade was kind of hard. I'm not sure what happened to the child's airway, but it was hard to intubate that child. I didn't do it. I mainly intubate adult airways. I've never done like a child or a baby. Hopefully one day I'm probably gonna have to do that either way. But the doctor ended up doing it, but it was hard. We had to bag the baby a couple times because the airway was just so hard to achieve. We actually almost called the anesthesia team because the doctor couldn't get the airway, but we got it. But the fun part was getting that ventilator. We were like, why is this thing not working? Because we were trying to get the tidal volume to go lower for what the baby weighs. You do mLs per kg based on the weight. And I hooked the baby up to the ventilator, and it just wasn't going low enough. But the doctor at the bigger medical center, the level 1 trauma center, gave us some settings. We were trying to figure out, why is it not going lower than what we needed to be? And turns out we used the wrong ventilator. We should have used that one to begin with. So we ended up switching to the adult ventilator. And with the adult ventilator, with the Puritan Bennett 980s, you can actually adjust the kgs of the patient, and that way you can play with the tidal volume and every other aspect that you need to play with. But we finally figured that out, and it was definitely an experience. And, you know, taping a child's ET tube is, you gotta do your X and you gotta do your Y. But they gave me this flimsy, rubbery tape, and I know we don't use it, because I remember this last pediatric emergency that we had, I'd use like, it was like cloth tape, but the rubbery, I wish I had an example to show you what it looked like, but it was like a rubbery tape, and I just didn't like it to begin with. It didn't rip well, and it wasn't secured, because we obviously try to tape it like 3 or 4 times, because the x-ray guy is like, it's too deep, it's in the right main stem, this child's lung is completely black on this side and then white on the other, and it was genuinely a process. But we ended up fixing the tube like the 3rd time, and what happened? The flight team came in, picked up the child, I shouldn't say baby, child's 1, I guess they're not a baby anymore, and a neonate, because that's really what that other ventilator, the first ventilator, was theoretically for a neonate, but I didn't know how old the child was at the time, so I just kind of just grabbed whatever, because I was told to grab it. But, you know, for future reference, you can use an adult ventilator for a child who's obviously 1 year old, but if they're like fresh out the womb and they can't breathe, obviously you would get the neonate ventilator and play with the settings with that. But, you know, we had to do pressure control because the baby wasn't taking enough breaths. We had to change the rate to like 30 or 40. That's kind of the range for it. And you always got to have an FiO2 less than 30% if possible. So it was just something to play with, but it was definitely an experience. Babies don't necessarily follow the rules like adults. You know, adults, it's more cardiac. Children, it's more respiratory. So it's important to just know the dynamics of either or. And whenever the flight team came through, I guess, I don't know if that was the flight doctor or flight nurse, but, you know, the doctor at the other facility wanted us to get a ABG or a VBG. And, you know, we asked the nurses to get a VBG while we were jamming out with the ET tube for like forever. And we're looking at the results, and I'm like, this is the VBG results, and I'm looking at the results, I'm like, wait a second, this looks arterial, because the SaO2 is 99%. And if you guys know how hemodynamics work, only oxygenated blood can get that high with a SaO2 of 99. VBG, that's not necessarily possible, because venous blood is deoxygenated blood. And everyone's like, oh, no, it's VBG. Even though it was VBG, I'm 200% sure it's ABG. You could tell by the SaO2, that's how you know. So the nurses theoretically, no, they did get an ABG, but they tried to say otherwise. But I mean, it still turned out how it should. Now, I don't know what happened to the child, but having emergencies with children, it's always scary for everybody. You know, I remember my first emergency. It was Christmas Day. Baby had some type of, the baby had some child, gotta stop saying baby. The child had some type of cancer. And I just remember, you know, we did everything for that child. It was the same doctor too, that for both child instances. And I just remember hearing that mom's wailing because their child died. Man, that haunts you forever. And that's, you know, just to have a child die on Christmas is insane. And obviously sad, but that's what you're going to be exposed to as an RT. You never know. You truly never know what you'll get whenever you get the ER. You can get a drowning child. You can get gun shootings. You could get someone's, you know, there's car accidents. There's so many things you never know, but, you know, those are things you'll be experiencing as a respiratory therapist. You know, all those little scenarios that you do in clinicals or not clinicals, in school, where they say, oh, car accident, intentional pneumothorax, gunshot wound. Like those are really a thing. Like that, it happens out here. People don't necessarily, people don't necessarily take precautions that they should when it comes to, you know, motorcycles, and they don't wear helmets, and they don't wear the right clothing, so you'll see their skin hanging off of them, you'll see their leg mangled. It's just like, you know. But that's why sometimes I genuinely do want a break, but you got to get this money. And I know a lot of people realistically need money, but that's why I like helping people, but I also like money. Let's be realistic. We need money in order for us to live in houses, pay for gas, go to work. Because if I don't, I'll be homeless. That's just how it is. But pediatric emergencies are just insane and just something to get used to. And hopefully, if you, whatever respiratory therapist that you do decide to become, whether it's an adult, pediatric, flight RT, travel RT, you're going to experience something to where it's going to change your perspective on life, what you need to do as a respiratory therapist, and it's definitely going to challenge you to be a better respiratory therapist, because you obviously want to help people. You obviously want this person to live. That's why you are doing what you do, your airway duty. And though a lot of people don't appreciate respiratory therapists, just know I appreciate all of you. I really do. And me being an RT myself, you're not forgotten, because I know what you do. Because if the patient doesn't breathe, they die. Now, I do think you guys should get paid more, depending on what state you're in. But, you know, it's genuinely something to really consider and research and learn from. So for all the students who are watching my content and you're new or you're old or whatever, it doesn't matter what age you are. As long as you're competent enough to do what you're supposed to do as a respiratory therapist, don't be lazy. Make sure you learn how to do things. Learn all the tricks the older RTs be doing. Look up the newer RT tricks. It's okay to do either one, but just make sure you don't be a lazy respiratory therapist. Always make sure you're doing what you're supposed to do. You know? Just because someone else is doing a bad thing, don't be like that person. Genuinely, and I mean this seriously, do what you're supposed to do. It's rewarding. I've had people dying, brought them back to life, and they're like, thank you. Oh God, thank you. That's pretty cool that we brought them back to life with CPR. Now, I'm just doing airway duty. Man, I do occasional CPR. I'm not going to say I just do airway. I kind of do a little everything. But I appreciate you guys, and you are appreciated. And I don't want you guys to forget that, even if it's not really recognized in your hospital or your field. With that being said, thank you guys for watching. If you're new, if you're old, to the channel, please hit that subscribe button, leave a like, and comment. I really appreciate that. It helps the channel grow. Hopefully one day I can get this channel monetized. I would like that. And I'll see you guys in the next one. Bye-bye.